Hi, I'm Kathy Toronto with AesthetiCare Medspa and Wellness, and I'm so excited to have Dr. Haver here with us in Kansas City. What a huge honor it is to have her here. So one of the things that we always look at at AesthetiCare is how to bring in the best technology, the best treatments right here in the Midwest. And there's no one better to have here today than Dr. Haver.
Aww.
If you haven't followed her, you absolutely must. If you have not bought her New York Times bestseller, The New Menopause, you absolutely must. It is a life-changing book. It's changed my life, so thank you very much.
So welcome.
I'm going to get emotional, but thank you very much. So is there anything that you want to say to Kansas City or just, about kind of your overall look on menopause and really what's driving you to make so many changes in people's lives?
So menopause is inevitable, but suffering is not. And for decades, lifetimes, centuries, women have hid their symptoms, through shame and through not talking about it. And what I really love is the book gives a groundwork for you to understand what's happening to your body and solutions that you can utilize to not suffer and live a long and healthy life after reproduction ends.
I just love it. I've learned so much from your book. Thank you for sharing your expertise with all of us. And not just sharing the expertise, but also coming here and engaging with us and creating conversation about something like you mentioned that we just don't talk about. And it's like, I just want to get up and shout from the rooftops, like, let's talk about it. Let's help each other out. So thank you for doing that.
You're so welcome. Happy to be here.
Good evening and welcome. I'm Kathy Donovan. I'm part of the ownership group here at Rainy Day Books, and we are so happy to have Dr. Mary Claire Haver here tonight to discuss her new book, The New Menopause. Before we get started, I'd like to extend a huge thank you to Lockton and AesthetiCare Medspa for the sponsorship of tonight's event. It is through the support of our sponsors like AesthetiCare and Lockton that we are able to bring incredible authors and thought leaders to our community. So a big thank you again. I'd also like to recognize two people who really helped us connect to Dr. Haver. The first is Katie Moreland, who on many occasions this past year would send me posts and book links about Dr. Haver, asking if we could please possibly get her to Kansas City with Rainy Day Books. She also helped with our connection to Lockton in order to do so. And I also want to thank my friend Melanie Barton, who happened to be personal friends with Mary Claire and put in the good word for Rainy Day Books in Kansas City. So this is how we do it. Thank you. We have a wonderful discussion for you this evening with Dr. Haver, and moderated by Alexis Del Cid. Alexis worked as a television news anchor and reporter across the country for nearly 25 years. You may remember her from Better KC on KCTV5 here in Kansas City. She left television news 3 years ago to spend more time with her family, including her father, who has Alzheimer's disease. And now you can see her anchoring and reporting for the Medical News Network at the University of Kansas Health System. So let's please give a huge warm welcome, a KC welcome, to Dr. Mary Claire Haver and Alexis Del Cid.
What an incredible crowd. Did you want to? Oh, we want to. Is your microphone on? Hello? Testing. Okay. I think you want to do something first, don't you, Dr. Haver?
Okay, can y'all humor me? Everybody hold up your book so I can take a selfie.
What an incredible crowd. And I love that I'm looking around and I'm seeing a few men in the crowd, which is incredible. Thank you for supporting the women in your lives. We won't make you stand up, but you are recognized. Huge thank you to Rainy Day Books and Kathy Donovan for putting this entire event together and bringing someone of this caliber to Kansas City, Dr. Mary Claire Haver. Rainy Day Books is a Kansas City institution, and by being here, you're supporting Rainy Day Books, and what a fantastic reason to come out and be here. And a huge thank you to our sponsors. We have Lockton and AesthetiCare. You locked in? Yeah. All right. AesthetiCare, where are you at? All right. Okay, there you are. Thank you so much for being here. It's going to be just a fantastic evening. Dr. Mary Claire Haver, thank you so much for taking the time to come to our city. As you can see, you have quite a fan base.
This is the biggest event I've done, just me, so.
It's interesting because your business and your message, you're a juggernaut. I mean, you have really gained millions of followers, so I think this is probably just the first time you're seeing in person how many people listen to you and are absorbing your knowledge and are so grateful for what you're imparting on us, because it's a subject that hasn't been talked about nearly enough. So thank you for that. I want to start by just running off Dr. Haver's credentials, because this is, I want to see your business card after this to see how full it is. Okay, Dr. Mary Claire Haver is a board-certified OBGYN, Certified Culinary Medicine Specialist, Certified Menopause Provider, founder of Mary Claire Wellness, focused on health for women in their post-reproductive years, which hasn't happened ever until you, so thank you for that. Best-selling author of The Galveston Diet, also an incredible book, and her newest book, The New Menopause, which you all have a copy of. Dr. Haver, just to get started on your journey, there's so many interesting layers to your journey. You were going to be a geologist.
My undergraduate degree is in geology, and it's how I met my husband. So
where's Hubs?
My engineer husband. We met at the coffee pot at the oil company, and he ended up having to put me through medical school. Surprise! Like, I think I'm going to go to med school. He's like, cool.
And then it wasn't until well into your medical school journey that you realized your real passion was helping women in perimenopause and menopause. How did that happen?
So, we didn't receive a ton of training in menopause. I mean, I knew it was a part of reproductive life, that the ovaries would kind of bail and we just get on with our lives and not be able to have children anymore. So I got about an hour in medical school, and then in my 4-year OBGYN curriculum, I think I had 6 hours total. And we had no menopause clinics, no nuance training. We never even discussed perimenopause. It wasn't a thing. So I was a very good OBGYN, except for menopause. I was a horrible menopause doctor, and it all gets lumped together, right? And why should all of women's health after reproduction be dumped in the lap of the poor, busy OB-GYN? I'm trying to do pap smears and do surgeries and deliver babies, and then having these women coming in with multiple complaints, and and all I was taught was, well, this is kind of what women go through at this age.
What was the, I hope you can retell this, when you were in medical school, you were a resident, the WWs? Okay. This will make you mad.
So here I am, my second block. So any physicians in here, you've done residency. So my second block, first block was labor and delivery nights, okay? And then I rolled right out of that into gynecology clinic, GYN. And so this is back when we had paper charts, so I'm old. There would be about 70 charts stacked up of all the patients to see that day. And the upper levels would run to the charts and pull the surgery cases, okay? They want to operate, they need to get their numbers, important stuff, okay? And then the next levels would go in and pull things that were interesting, and they would just leave what was taught to me were the WWs behind. And so I go grab my chart, and I open it up, and it's a woman in her 40s with multiple vague complaints. She was not sleeping well, she was gaining some weight, she had some libido issues, she had some headaches, just kind of lots of little things. And my chief resident comes up, and this is Texas, so we're in South Texas, and he's got his cowboy, I'll never forget this, scrubs, cowboy boots, and his white lab coat. He's like, "What you got?" And I said, well, Ms. Smith, she's 44-year-old white female, G2, P2 with, y'all know what that is, who's coming in with, all these complaints. And he goes, "Oh, she got a thyroid problem?" I said, "No, her last testing was all normal." And he goes, "You got a WW." And I said, "Excuse me?" And he said, "That's a whiny woman."
Told you it'd make you mad.
And she was she was white, so it was actually a WWW, but I left that part out of the book because it gets people upset. So, and he said, "This is just what people go through at this age." And no one taught me to ask why.
If it was a guy having a problem with his libido,
it would be a national emergency. Well, that's what happened with Viagra.
Right.
I mean, Viagra had the fastest transit time through the Food and Drug Administration. Literally, it was a record time of approval to get sildenafil through, to get Viagra through. It was like less than 2 years, which is unheard of. And yay for men. It's a great drug. It works amazingly well. Do you know how long it took to get Addie through? The female equivalent? 7 years. They got turned down once. They had to reapply. And they had more, the whole story behind kind of the lens of how women's health is viewed is pretty sad.
Like the Army National Corps working on that for men's libido problem. Not really, but I mean, come on. It was so much effort.
It was like getting the vaccine out for COVID. It was faster.
Right, they fast-tracked that. Yeah. Operation Warp Speed for that ED drug. So I gotta say, you're this guru here, and I'm so glad you're here. 51-year-old woman here, well, I'm turning 51 soon, sleeping with my bedroom at 48. My husband's waking up with icicles. The only thing I had learned about menopause until, and this is I feel almost embarrassed, but I can't be the only one. I thought it was 6 months of hot flashes and then it was over.
I was under a similar impression, to be honest.
And it's not.
The only thing I was taught that was really clinically significant for menopausal symptoms were vasomotor symptoms, which are most people understand as the hot flash. And they would go away eventually on their own. And, but we were giving hormone therapy in most of my residency when the patients came in and complained of severe hot flashes. But when I graduated, the year I graduated was 2002, and that was when the Women's Health Initiative was released. And there was a full stop on hormone therapy, was just pretty much taken off the table. It was just a no-go zone. Not an option.
One of the things that also you said that I think it will hit a lot of people like a lightning bolt is that this is a third of a woman's life you're talking about. So you got 5 hours in all of your studying to be a doctor on a third of a woman's life. We're talking about not just 6 months of hot flashes, we're talking about 30 years plus.
And at the time, the bulk of the research in menopause was done on vasomotor symptoms. We were learning a little bit about osteoporosis, but again, that's just, a natural part of aging is complete destruction of your bone density. And that's fine, right? And we knew about some of the genital urinary system syndrome. GSM is what we call it now, genital urinary syndrome of menopause. Used to be called vaginal atrophy, but that sounds terrible. Is that
dryness? Is that what you're talking about? Painful intercourse,
loss of elasticity, loss of functionality, extremely painful relations. Yeah.
Again, if that happened to a man, this would have been taken care of.
We just tell them to have some wine.
Ago.
Yeah.
No offense, but I know we have men in the crowd, and we love you, so I hope you don't think we're saying this in an angry way towards you.
Poor guys.
You guys are good guys, good guys. Medically speaking, how is menopause defined, and how do you wish it was defined?
So, to this day, menopause is defined by the absence of menstruation for 1 year, naturally. Okay, now we have surgical menopause and chemotherapy menopause, like ways that we iatrogenically kind of remove the function of the ovaries through surgery and chemotherapy. and radiation, different treatments that will kind of knock out the ovary, but we medically define it as the absence of a period for 1 year. Now, here's my question. How do you define menopause in leap year? Is it 366 days? What if she was born without a uterus? What if she has a Mirena IUD? What if she's had an ablation? What if she doesn't have regular periods like me? I had PCOS. I gaslit myself in my own menopause because I did not have regular cycles and I couldn't figure out what the hell was wrong with me. And this was my job, And so my problem, and there's many thought leaders in this space who, it's not the lack of periods, that's just a symptom, and a symptom that not every woman has. It is the loss of ovarian function. That is what menopause is. So to review, so we're all on the same page, we are born with all of our eggs, females are, right? And we start losing them the minute they're formed. And so at birth, we have 1 to 2 million eggs on average. By the time we're 30, we are down to 10% of our egg supply, and by the time we're 40, we're down to, on average, 3%. Menopause represents no more eggs. No more eggs, you don't ovulate, you don't produce those sex hormones every month. Perimenopause, so in a normal reproductive cycle, in someone who doesn't have PCOS and is healthy, everybody has probably seen the hormone curve with menstruation. We have these very predictable ebbs and flows of hormones, of FSH, LH, estradiol, progesterone. Testosterone's fairly stable. It goes up and down a little bit, but not clinically significant. And that's repeatable month after month after month after month. On day 14, she's going to do this. On day 28, she's going to do that. On day 3, she's going to do whatever. But in perimenopause, why we ovulate is we have these glands in our brain called the hypothalamus and pituitary that are sending signals. The hypothalamus talks to the pituitary talks to the ovary and says, here's some hormones, it's going to make you ovulate. When we reach a critical threshold of egg supply, we become resistant to those same signals. So they don't work as well anymore. So we need more of those stimulating hormones. The brain starts getting upset. Where's my estrogen? Like every month, I knew on day 14 I was going to surge, and now it's not happening. So it becomes a very chaotic, what used to look like an EKG each month, now becomes a zone of chaos. And that's where it gets really confusing, because you might still have regular periods. But, to get those periods to go, the brain's having to work a lot harder to send those hormonal signals down. And the brain loves regularity. So some of the first signs and symptoms that we see in perimenopause are cognitive and mental health, before the hot flashes and before the cycles become irregular. And that's where we need the research. This is what we need to be talking about. Besides and what else? We have estrogen receptors. I did not know this. In almost every organ system of our body that line the endothelium, that, our blood vessels become stiffer after menopause. We are much more likely, we have much more rapid deposition of plaques and atherosclerosis, in our blood vessels, besides what's happening to our bones and our genitourinary system and our brains and our guts and the belly fat and, the things that drive people to my office. So what, for me started as frustration with being terrified to take hormones because my hot flashes were so debilitating and I felt like I was throwing in the towel. Then became a journey of discovery of, wait a minute, this is way more than just hot flashes. This is my whole body.
That's so interesting. Along those lines of being your whole body, you have a hot flash now?
It's a cute jacket.
It is a cute jacket. It's better off, though, if you're having a hot flash. One of the things that was fascinating is to hear you talk about frozen shoulder syndrome. Never in my life would I associate shoulder pain or frozen shoulder with menopause. And there are so many things like this, but can you explain why you get a frozen shoulder during menopause?
So there is a condition that is now recognized called the musculoskeletal syndrome of menopause. Estrogen is a powerful anti-inflammatory hormone, and there are estrogen receptors in our tendons, bones, joints, and so we see arthralgias, arthritis increases, arthralgias increase, and frozen shoulder is adhesive capsulitis. So the capsule around the joint of the shoulder becomes literally frozen from scar, it looks like scar tissue. And so estrogen is better at prevention than cure. And so women on HRT, we know this from the data, have less incidence of frozen shoulder. If they do get it, they tend to have a shorter course, and it is less severe.
This makes me so sad because my grandma couldn't move her shoulder, both shoulders above. Oh, she could never do that. We had to rig different systems in her house so she could reach plates and things. And that was for the last 20 years of her life. So had she had access to hormone therapy.
And an orthopedic surgeon who didn't blow her off, or PT,
Right.
you know, so it's treatable. You need early PT, get in there, do all the needling and all the thing. Any physical therapist in here, you know, it requires treatment.
Absolutely,
But you're
yeah.
much less likely to get it if you're on HRT.
So if you have a frozen shoulder and you go to the doctor for it, is there even an insurance code for menopause-related frozen shoulder?
There's not a Medicaid or Medicare code for menopause. Like, it's not a thing.
Do you have any tricks you could tell us? Like, what do you say when you go into the doctor if you have a prayer of getting it treated or
So there is a
covered?
code for frozen shoulder,
Okay.
but not for menopause related. And actually, most clinicians still don't understand that menopause is more than just hot flashes.
A hot flash for 6 months. That's maddening. Another thing that was really powerful was to read in your books and your interviews about how menopause treatment falls in the laps of OBGYNs now. That's what an OBGYN does. But if it affects your shoulders and your joints and your belly fat and your emotions, shouldn't every specialist be trained?
I really feel like every clinician who touches a female should have, you know, the basic menopause education, but we're just not doing that, and it gets siloed to OBGYN, and we're busy. I mean, I don't do generalist practice anymore, but you know, I'm running to go deliver babies and running back to do the pap smears, and how in 10 minutes, and half of that's with their legs in stirrups, am I gonna be able to like break down? I mean, menopause is complicated. Doctors love ducks. If it looks like a duck and walks like a duck, it's a duck. You know, we got checklists and whatever. Menopause is a really weird duck because it has all these estrogen receptors are expressed in different levels based on ethnicity and age and, you know, your lifestyle. I mean, all of that plays into it. So each of us in here has a very different menopause. And so it's really hard to recognize. So when patients come into clinic, I'm doing a ton of blood work. I'm not doing a lot of hormone testing because I can listen to a patient and believe her. You know, I don't need a blood test. But a lot of things overlap, and you know, we had this, I was taught that females tend to somaticize psychological symptoms. This was taught to me. This was handed down from generations and generations of training, and I still have to pull myself back, even when I just do menopause care now.
What was that? Can you say that again?
So that women tend to take psychological symptoms and make physical symptoms out of it. Men don't do that, only females.
So
Is what I was taught.
Think your way
The
out
whiny
of it.
woman was just kind of, you know, and then even today in the literature, when you go, I read research articles every single day. I have an alert on PubMed that I get an email every morning, every time menopause and perimenopause is mentioned in a peer-reviewed journal article. And today you will see, oh, but it's a tough time in her life. Oh, you know, she's dealing with a lot at this age. I've been dealing with a lot since I was 12. You know, like, something is different in me. And that's what my patients were trying to tell me. And it took me stepping back, letting some of that training go, and realizing she's right. And sadly, it took me going through a really rough menopause in order to open those doors and change my line of thinking.
And that's what I was going to ask you about when you were going through menopause.
I'm still in menopause.
Still in menopause.
Forever, till I die.
For the next 30 years, right? You were going through such a hard time in your life. You'd suffered a series of family losses and were feeling rotten, and you just had attributed that. And grief is real. It does cause all these other things that you're talking about, but it never dawned on you are in menopause.
No, I mean, I never had regular periods, so, and I had been on birth control to suppress polycystic ovarian syndrome for years and years and years, and I had done well on it. It was great for me. And so I had, when Bob, my brother, who I talk about in Galveston Diet, his end of life kind of course began, he had hepatitis and HIV. And I had, my practitioner and I had decided, all right, let's stop the pill, kind of see where I'm at. And I just, rushed to home to go take care of him, and, he passed away, and then I just was in a fog. It was his birthday, and then it was Christmas, and, I was just not sleeping and not feeling good. Everything was achy. I was a raging lunatic, and I just thought, God bless you, Chris, through all that, my teenage children. And I just felt like this is my grieving process, and certainly that was a part of it. But 3, 4 months, 5 months down the road, the grief starts to lift, and I still feel terrible. Right. Terrible. And I was like, and then the hot flashes really started rolling, and you can't, the reason why vasomotor symptoms are really like the hallmark of menopause and have really been studied, because you can't blame them on much else, right? Joint pain you can blame on anything else. A lot of things look like menopause: hypothyroidism, autoimmune disease, inflammatory disorders, and that's where I spend the money on the blood work for my patients, is looking for, making sure those things aren't going on as well. And so for me, I called Dora, who was the nurse practitioner I'd worked side by side with, and she had done my pap smears and sent me for mammogram every year, and said, hey, I can't live like this. I'm not sleeping. The hot flashes are unbearable. And she's like, okay, well, let's start some low-dose hormone therapy. And I was like, okay. And I very reluctantly started. I felt like I was throwing in the towel.
What was scary for you?
I didn't want to go on antidepressants, which was the other option. It was pretty much, we were just offering antidepressants as the first-line therapy for menopause, which should not be. So,
what was scary for you when you heard the words hormone therapy?
I thought I was going to get breast cancer.
Oh, interesting.
20 years after the WHI. So I am board certified. I do my recertification exams every year. Okay, we have a series of articles that we read, and we take some little quizzes to make sure we read them, and off we go. And that's how we get our CME, right? Our continuing medical education, and we go to a few conferences here and there. Never had anyone told me or showed me that the WHI had been debunked. I was still operating under the 2002 erroneous reports. Most clinicians in the U.S. are still operating under the 2002. Once that genie got out of the bottle, that is a hard lady to get back in. There will be oncologists today who will swear on a stack of Bibles that estrogen will cause breast cancer, because I lost 2 brothers to cancer, another to hepatitis, almost all of my paternal family to cancer, and half of my mom's brothers and sisters and dads. And so I'm like, I'm so high risk. I'm going to die anyway, so I might as well die happy, so I'm going to try it. And lo and behold, of course, the hot flashes go away. Of course, I start sleeping better, but the joint pain is better, and I'm thinking clear. I'm doing better at work. I'm like, everything is kind of better.
How soon after starting hormone therapy?
I remember like week 2 going, is this going to work? Because I was looking for hot flash relief, right? And it was like 3 weeks when, plus I wasn't sleeping. So once you don't sleep, everything goes cattywampus. So, you're in this negative feedback, kind of crazy traffic circle. And so once that slowed down and I could get good rest, I was still taking call, still staying up all night delivering babies, 2-3 nights a week sometimes. And, all of that was feeding into it. But once I could rest, then I was like, okay, this is a freaking miracle,
How soon between that and you starting your practice? How did you get from there to starting?
So I was at a large institution in Texas where I had been a residency program director and in academics off and on for 20 years. And went through menopause. My first interest in the space, once my hot flashes were gone, I was like, I still thought I was going to get breast cancer, but oh well. Hopefully it'll be later in life. And but I was frustrated with the weight gain. And so that's where Galveston Diet came, of like, what could I do nutritionally? And I enrolled in the culinary medicine program at the time it was through Tulane, now they have their own board. And really loved everything I learned there. I learned nothing about nutrition in my med school. And I was a geologist undergrad, so that wasn't helpful. I was good in radiology though, because I could see the stuff. And so I was like, I want to do this. So I made this nutrition plan for myself and my girlfriends, and I was giving it out to patients. It was like Xerox from Office Depot down the street. And I would just hand it out, and then they were sharing it, and all the nurses started doing it at the hospital, and it was just like a little fun thing. And then I took it to the internet for fun. And within a year, we had thousands of people doing Galveston Diet online. And then, but the more I was talking about nutrition and menopause, the more I was reading and the more people were asking me more menopause questions, and I kept researching, and I was like, wait. And then I went to my first big menopause conference because they wanted me to go and talk about menopause and nutrition. So I'm up here on this panel talking about fiber and vitamin D and all the things I talk about. And I hear Avram Blooming and Carol Tarvis from Estrogen Matters. Anybody read it? And Sharon Malone, and up on a panel, and I cried my eyes out in the audience because it was the first time I'd heard that the findings from the WHO had been debunked.
Oh my gosh.
And that day changed my life. And I thought, this is my path. You know, I love all the nutrition stuff, I still talk about it, but I was like, I need to want to talk more about menopause and the safety of HRT and the benefits. And then when I started researching for the new menopause, then I was getting into the joint pain and the brain fog and the mental health changes, and, you know, just the whole world exploded.
I have a follow-up question about the joint pain. How does hormone therapy help the joint in your shoulder? Are there estrogen receptors in your shoulder?
Yeah. In the actual joints, and estrogen provides a level of and protection from inflammation, and then you just whip that away. So all the things you kind of got away with,
right?
That's why everyone doesn't have joint pain, but some people are predisposed, and we kind of get away with stuff in premenopause, and then all those habits that really weren't bothering you before now start stacking up because you've lost the protection.
The aches and pains, it hurts you. You can throw your back out picking up the remote for the TV, right? That can be attributed.
I would just sit in a chair.
Right, standing up.
And be like,
right.
You know?
Exactly. So that can be attributed possibly to menopause. It's not just, oh, I'm getting older. It's just I'm more creaky.
It could be. It could be.
What about body fat? For so long we heard calories in, calories out. That is starting to change, thank God. We're not going for that heroin chic look that was popular in the 90s.
2000.
Yeah. But it's still, to physical trainer, are personal trainers on board with you?
Some.
Okay.
Some. There are other people out there who had really big followings who have made, it's $1 billion industry, right?
Right.
Who were just calories in, calories out. And calories are important, but my patients were coming in droves. It happened to me, and I'm not much to me, but all of a sudden, what is this? And I'm like, nothing changed in my diet and exercise. Mm-hmm. Nothing. And they're all coming in saying the same things. I'm doing nothing different. I'm walking X amount of miles. I'm doing the aerobics and and I'm eating the same. I'm calorically restricting. And all I was taught to tell them was it's impossible. Even books say now, well, you tend to move less as you get older. And this just happens to women. So what they found is that females tend to gain weight regardless of their menopausal status, but what is changing is our body composition. We are losing muscle at accelerated rates. Our peak muscle mass for most humans is about 30, 28, 25, 30. And then we start losing it due to the aging process. You can build after 30, absolutely. You can bodybuild. But who's bodybuilding at 30? What females in here? I was doing aerobics. I need to be skinny. Right. My goal was to be thin, and thin was healthy, and that was it, right? And so in the body composition changes, we're losing muscle. That muscle is driving our basal metabolic rate. Calories are important, okay? But we're also driving new fat to the abdomen, to the intra-abdominal cavity, and that is visceral, or in lay terms, belly fat. And that visceral fat is metabolically very different than the fat that gives us our curves. Most of that is genetic and a little bit of caloric in and out. But the intra-abdominal fat, you can have a normal body weight, be completely looking thin, and have tremendous visceral fat. And it is driven by inflammation, cortisol, and the loss of hormones.
But God gave you your curves, but menopause gave you your belly, right? What does visceral fat look like? Is there a test to detect it?
So, if any surgeons in here, when you put the scope in the belly, you know what it is. It's bright yellow, it's everywhere in the abdomen. But it is measured, typically you can see it on MRI, but no one's doing that. They can color code it on certain CT scans, on CT images, but DEXA scan. So our DEXAs measure bone density generally, but they're scanning the entire body, and most DEXAs can have an output for body composition. In my clinic, DEXAs, buy a DEXA between $60,000 and $70,000 for a good one. So that was, when I first started the clinic, that was not going to be an option. So, but I was able to get an in-body scanner, which is an electrical impedance scanner, and I'm able to give my patients muscle mass and visceral fat measurements, as well as weight.
So what do you say to a woman who comes in, 50-year-old woman, can't lose belly fat, you call it visceral fat? What do you prescribe to her? Do you use a blend of your hormone training and
Right.
nutrition?
We start, we look at, it's looking at what are her risks growing old. So when patients come to my clinic, okay, now I have an hour with my patients. I have a very bougie private, full disclosure, I do not take insurance. And so I can spend an hour with my patients. So I can do all the labs that I want to do. So I'm not going to have an insurance company directing me as to what I can and can't do, And it just depends on her goals. So we try to put out the menopause fires first. So whatever's keeping her up at night, she's got to sleep, And so we discuss HRT if she's a good candidate. We start with that. We give her a nutrition plan. I now have a background in nutrition. I can do that. I make plans based on her muscle mass and her visceral fat, on how many carbs or fat and what's her basal metabolic rate and yada, yada, yada. So then she comes back in 3 months. And so some patients come back in 3 months. Thank you very much. We've cut down the visceral fat. She's healthy, feeling good, looking good. Everything's great. Go on. But about half, we're adding in GLP-1s.
Talk more about that, GLP-1s. I heard ooh in the crowd. And
So GLP-1s are a class of medications. You might have known of them as Ozempic or Wegovy. Semaglutide, tirzepatide are the commercially available formulations now. And at least in our patient population and in my colleagues, it is absolutely miraculous. So, for patients who are good candidates, they are losing visceral fat. And in my clinic, we are doing extensive counseling around muscle mass. So one of the things we worry about is if we severely calorically restrict, most females will tend to lose a lot of muscle. So how do we not do that? One, we make sure they're getting enough calories to stay healthy. And we're really, really protein forward on their nutrition recommendations and resistance training. So we're doing a little bit less cardio and adding in more weight training. And then we're coming in every 6 weeks and we're measuring their muscle mass.
So you're measuring, hoping that there's more of the woman, not less of her.
Well, we're wanting, it's like the GLP-1 puts her in a position where for the first time in her life, she can eat more and not less. Like she's fighting to eat more. She wants more protein, more fiber, more fruits, more veggies. And it's really, really a cool thing as a physician to watch. Not only her mental health is better, she's sleeping better, but we're putting her on a path, we're helping her build a body that's gonna be strong and last her the next 30 years. Because here's where we are right now. A female can expect to spend 25% of her life in poorer health than her age-matched male counterpart. So we're living longer than men, but we're not living healthier. We're much more likely to end up in requiring long-term care, losing our independence because of loss of cognition, and loss and frailty. So that starts early. That starts in your 50s, and so we're recommending early DEXA scans. Waiting till 65, I think, is the biggest mistake. Most orthopedic surgeons will agree with me. And if you invest in anything, go pay for a DEXA scan, $99 at most of the little outpatient centers. Know your bone density, especially if you're thin. So thinner women tend to have lower bone density. And there's lots of stuff you can do, but it's like instead of that fight to eat less and be thin, I'm like, eat more, be strong, get bigger. Be scared when you lose weight.
More muscle.
More muscle.
More muscle. And the bone density is so real because
50% of women, 50% of us in this room are on the course to have an osteoporotic fracture before we die. And if it's your hip, after the age of 65, I'm not trying to scare you, 30% chance of death with surgical repair, 79% without it. If you're not healthy enough to or can't afford the surgery, 79% will die in 1 year. And it is a miserable, miserable existence. It's not fun to have hip fracture. and the recovery is awful. And so this is preventable in most cases. So this is what I'm talking about. Not just looking good in a bikini, I would be nice, but this is, my patients are coming in and they're looking at their mothers and their grandmothers. I'm like, look, if your mom is 90 and she's cooking and cleaning and taking care of her, I mean, she needs some help, but she's healthy and has her brain and everything's good, do what she does. Don't worry about me. But if she's requiring long-term care, like my grandfather, don't recommend this, drove a truck the day he died, okay? He was functional. He had a heart attack and he died and it was over, okay? My grandmother was in a bed for 10 years declining, requiring long-term care. Loved her, beautiful woman. It was awful to watch. She did not want to live like that. So like my patients coming in are like, what can we do to not have that?
Right.
And it starts now.
It's so interesting because as a woman, no one ever talked to me about bone density until I started thinking about it on my own. I don't remember a doctor
Osteoporosis is natural.
Right.
Stop weaponizing natural against women.
Yeah. Do we start losing bone density because of menopause or because of not working out the right way or not eating the right way?
So all of it. Aging, so the aging process takes some of our bone density away. We peak at about 30 and then start losing it, but the first 5 years of menopause is the greatest acceleration of bone loss we're gonna have in our lives.
Wow.
So waiting till 65, the cow's out the barn,
No.
So knowing that you're osteopenic, osteoporotic, knowing that hormone therapy is FDA approved for the treatment of osteoporosis and the prevention,
Can you take hormone therapy for osteopenia?
Absolutely.
Asking for a friend.
Absolutely. Now,
Yeah.
add in the weight training, the protein intake, Fortibone collagen, the collagens that have been studied for bone density, all of it. I'm like, stack every card in your favor.
Right.
Right? Don't just rely on one thing.
It's so fascinating that bone density scans aren't recommended till you're over 60, right?
It's unbelievable to me how the health of women is absolutely, after reproduction ends, it's not great up until, through reproduction, but like after reproduction ends, we're just an afterthought. These studies were done on men, mostly men.
Like tiny men that they made look like women?
And, when we look at cardiovascular disease, and, so I talk a lot about, there's lots of data looking at statins. And, the big 4 studies that were done on statin therapy were done mostly on men, but when they deaggregated the data and looked at men versus women did not see prevention of heart attack from statins. Their cholesterol went down some, but it didn't keep them from having a heart attack. The American College of Cardiology just published in April that they looked at women on statins, age matched them to men on statins, and they all had, matched them for diabetes and all the risk factors. And they found that, and they did calcium cardiac scores a year apart, and they found that the women were having much higher rates of acceleration of their cardiovascular disease on a statin. And the authors suggested statins really aren't working that well for women to prevent heart attacks. Now, people get mad at me when I say that, and I'm like, we need to study this. We're calling for more studies. I'm not saying get off of your statin. We got to figure out something better for you. But for now, that's all we got. So
if you were to Google, menopause studies or do a search for menopause studies in the Google of medicine, what would come up? PubMed?
Mostly things around, when you look at the most hits and the most studies, they're mostly done on vasomotor disease, vasomotor symptoms.
Vasomotor meaning hot flashes? So all this
sweats.
Research is done on hot flashes and night sweats?
So HRT was developed to stop a hot flash. Birth control was developed to stop a pregnancy, to prevent pregnancy. And the biggest difference between the two is dose.
Really?
Mm-hmm. You need about 4 times-ish as much of estrogen and progesterone to stop ovulation, to tell the brain we don't need to ovulate. Remember those signals, that EKG?
Yeah.
And HRT was just given in enough doses to stop a hot flash.
When you look back on when you look at your culinary medicine creds, What does Dr. Haver have in her pantry? You know, if I was to go snooping around in your house,
Don't ask my
what are the
kids. They
things-
call me Ingredient Mom.
What are
So
they?
Ingredient Mom, it's a TikTok thing.
What are the 6 must-haves that you have in your fridge?
Avocado. Always have avocado. I'm an avocado a day girl because I'm trying to hit my fiber goals, and I love avocado,
Okay.
thank God. Nuts. We have like 1 million different types of nuts. We have lots of like protein now, you know, so we have chicken and beef, and pretty much once a week we'll meal prep some kind of beans, and I'll throw meat in there, and that's just something we can like have as sides, or I can, you know, take to the office for lunch.
What seeds? Are
Seeds,
the same as-
so like chia seeds, flax seeds, hemp, you know, I'll throw that in yogurt to get, so we'll have, and then I'll always have Greek yogurt for the high protein and the probiotics.
You talk
Berries, apples.
Yeah.
We haven't been home much. Chris, what else do we have?
So, do you ever?
Sometimes we have this unspoken, like, who's going to the store? Like, we just wait each other out, like, until there's like dust in the fridge, and then fine, I'll go, you know?
Do you, when it comes to the kinds of meats that you cook with, do you limit red meat, or do you you don't limit
I'm
any
an
of it?
omnivore, no. So we do a lot of beef, chicken, some pork, you know, the kids are gone, so everything's changed. When I was like
Right.
cooking for everybody, and now it's just he and I, and he actually does a lot more cooking than I do now because I'm traveling a lot.
If you could go back in time and talk to like little Dr. Haver, when you were watching the women in your life, your aunts and your mom go through the change, what would you tell her?
Educate yourself, because this is coming, and it's going to happen to 100% of us, and you're not going to be prepared. So you need to learn as much as you can about it. Don't worry about being thin. Stop that being a goal. Work on being strong. I tell my girls that, you know, strong over skinny, nutrition over calories. Don't worry so much about the restriction and worry more about getting the good stuff in. Probably watch your alcohol intake.
That was my next question. Is there any truth to a glass of wine a night is good for you?
No. But you can probably get away with one.
Okay.
Without it causing massive harm, but there is no health benefit to alcohol. It's a poison.
It feels like we're seeing more non-alcoholic beers and wines. They're taking
If I'm going to
shelves.
drink, I'm going to drink.
Yeah. Do you?
I'm also choosing not to sleep that night. So, and for me, there's no getting around it. More than one glass of wine, I am not, at 3 a.m., hello, she's awake. I cannot
is a
process it
choice.
like I used to.
It is a choice. You're choosing to have wine with your friends, and you're also
And I'm choosing not to sleep that night or sleep well. So,
How important is sleep for menopause?
like, I guard my sleep with my life. I had to stop doing obstetrics, you know, because I could not continue that sleep pattern. It was my 50-year-old birthday present to myself. It's like, no more babies. Beautiful part of my life, no regrets, but I cannot do that to myself anymore. I can't function.
We have some really good questions from the audience. I know that we collected questions from all of you, and I'm looking at the time. We would love to kidnap you and do a lock-in and just have you do like a sleepover, but we're going to take these questions one at a time. Is there an age or a life stage when starting hormone therapy is a higher risk? Can you ever be too old to start hormone therapy?
Not necessarily. So it seems that the time of your body is away from estrogen, and we have these diseases accelerate. Like, we're all aging. You know, heart disease is still the #1 killer of women. But women who started hormone therapy within the first 10 years of their menopause or before the age of 60 seem to have more cardiovascular protection. They had lower cardiovascular disease death and lower cardiovascular disease risk and lower all-cause mortality. So there seems to be a window of opportunity. Like I said, estrogen is better at prevention than cure. So if we can limit the time that your body is away from estrogen, we seem to do better. We do, we look at risk factors for cardiovascular disease. It does seem that, hormone therapy, there are risks and benefits to every medication. This is not, to everything we do. Tylenol has risks, aspirin has risks, hormone therapy has risks, so not everyone is a candidate, not everyone will choose it. You can be healthy without hormone therapy, it just tends to be a little harder. So, and I like to make things easy for me, and so, yeah.
I have a great question here about an IUD. Someone wants to know, if I have an IUD, do I need to have that removed before I have blood work done? And
No.
To have your hormones
Even if it's
tested?
progestin containing, no, you don't. You can
Okay.
start testing.
If you go through menopause at an early age, say 43, 44, and start hormone therapy, how long can you take the hormone replacement therapy?
As long as for you the benefits outweigh the risk, and that could be your entire life. It will always protect your bones. It will always protect your vagina.
Those are two
Forever.
important
And your
things.
bladder. Forever.
Will it help build bone mass? You say it protects your bones. So keep taking it, and you're...
Build, maybe not. It will slow down the loss. Now, to build, you must eat the protein, you must lift the weights, you must do the things. You can't get away from that.
Is protein more... Most people think when they have some osteopenia, osteoporosis, drink milk, but you're also saying eat protein.
Yeah, so when we looked at, when the WHI is just a data set, and I don't want to demonize data, right? It was just how it was interpreted. But some of the coolest stuff that came out of the WHI data set and the SWAN study and all these long-term female health studies, they looked at frailty scores and protein intake. And women who were having 1.3 to 1.6 grams of protein, and these are like nursing home ladies, had lower frailty scores just from protein intake. They controlled for everything else. So there's something to, we are under eating protein as females, probably because we're calorically restricting, because we want to stay thin, and eat the protein. So I tell my patients, we're going to prioritize, especially on a GLP-1, we got to prioritize your protein. Protein and fiber. You can just do two things for me. Let's start here. And foods rich in fiber, not fiber supplements. And this is coming from a doctor who sells supplements, in case you hadn't read the New York Times article. Okay.
I do have a question from someone about a GLP-1. She would like to know, what is the intersection between perimenopause weight gain and GLP-1 meds when you're not significantly overweight?
So right now, there is no clinical indication to start a GLP-1 if you are not diabetic or pre-diabetic or obese. So what if you are normal weight? Could it be helpful? There's stuff people are calling microdosing. The endocrinologists struggle with that term. The use of a GLP-1 in a normal weight person can be a little slippery slope, because you're going to calorically restrict from the GLP-1, and you might start losing muscle mass. You really, really have to fight to get to the gym and eat the protein. But we are seeing mental health benefits, and all this is being sussed out. We're just giving your body a hormone that it used to make in higher abundance, just like estrogen.
Right.
So in women they did a study, they looked at postmenopausal women on HRT, everybody's on a GLP-1, and then this group was on HRT as well, in the form of estrogen plus or minus a progestogen. And the combo group lost 30% more weight.
Oh, interesting. What are the key things? This is a great question, because you're in Texas and we're here in Kansas City. So what are the awesome key things that I should look for in a doctor specializing in perimenopause in my area?
So we don't have great clinical training in our traditional programs. Only 30% of OB-GYN programs today offer any kind of menopause training. It's just barely like a little elective, maybe a month, okay? So the Menopause Society has at menopause.org, has a certification. Do I think it's perfect? Absolutely not. But it's something. It's someone who is taking the onus, the impetus to go and read this book and take this exam, okay? So that's one place to start, is to go to their website and look for a certified provider. The other is, on my website, we have a crowdsourced, all my followers, I have hundreds of, probably close to 1,000 now, of providers recommended they wrote testimonials, and we divide them up by state and city. So that's another place. Talk to your friends. Call ahead. Do you offer hormone replacement therapy? Now, if the answer is 100%, what percent of patients get HRT? If it's 100%, that's a red flag. Not everybody's a candidate, not everyone's going to choose it. Every one of you deserve the conversation. And you're not getting that. So, and then if it's like less than 25%, that, or probably if they're not doing it, they're not doing it, you know. So, but it should never be 100%.
I think we have time for just a couple more. We're over? What's my time limit? I have to be transparent about this. We could talk all night. Okay, all right. We're going to keep you a little longer. Should you always take your progesterone orally, or can you get it through a patch?
So, yes. The oral micronized progesterone is kind of the gold standard for, because it is bioidentical and it has the best safety profile, at least in reference to breast cancer. In the WHI, it was the group that took estrogen plus the progestogen, which was medroxyprogesterone acetate, something called Provera, which is why they called it Prem-Pro, long story. That does seem to be problematic, but it still was not statistically significant, but it was slightly increased. So oral micronized progesterone, we have not seen increased risk of breast cancer with that, which is why most of us stick with that one. But Combi patch, like the transdermal progestins, it's a synthetic progestin. It works great. I like Combi patch. Some of my patients prefer it if they don't tolerate the oral progesterone. Where we struggle is with the progesterone creams. Progesterone is a humongous molecule. Unless you micronize it, which most of the compounders are not doing, it's really hard to get it through the skin. So Menopause Society is really anxious that these women are getting estrogen, which absorbs very well through the skin in their creams, but they're not getting enough progestin to protect the lining of the uterus. For that reason, we do pretty much exclusively oral progesterone if she can tolerate it.
Is it safe to be on progesterone if I don't have a uterus?
Absolutely.
Oh.
It's so good for sleep.
Okay.
So it's mandatory if you have a uterus, you must have a progestogen. But if you don't have a uterus, it's optional and works very, very well if you still struggle with sleep.
What's your recommended fitness program?
So if she said, you have to meet the patients where they are. If you're sedentary, start walking. Start easy, 30 minutes a day, 5 days a week. That'll cut your risk of type 2 diabetes by 50%, just walking, if you're sedentary. If you're walking, put on a weighted vest. Grab some weights. Okay, we're working to decrease your risk of osteoporosis and sarcopenia, low muscle mass to the point where you can't function. If you're doing all that, hire a trainer, get to the gym, learn how to lift safely.
Are there a couple things that you've talked about weighted vests? Are there any
studies, the reason why the studies were done on patients with osteoporosis and osteopenia, and they put weighted vests and put them in different, they had better balance because you're having to work a little bit harder, and they saw improvements in their bone density.
So just can you buy any weighted vest? Can you buy on Amazon?
They looked at different weights, and so it seems that the benefits for bone density start at 10% of your ideal body weight. So if you're like, and every woman knows their goal weight, I don't have to tell her. So if that's 130 pounds, you want about 13 pounds. But that can be heavy to start. Yeah. And you can get a reasonable one for $25, $30 on Amazon. So I'm like, okay, if you've never done this before, get 8 just to start and try it out, get used to it. I can wear my 8 for a long walk a 5-mile walk on our seawall in Galveston. But if I'm home and doing housework, or I'm just putting around the gym, we have a gym in our garage. It's very hot in Texas. But I'll put the heavier ones, like the 12-pounder. My husband got into them, so we have 6. Oh. And they go up to 30 pounds, which is a lot.
And just wearing the weighted vest takes care of all the bones in your body, because it's actually affecting your spine, which is something I
so
didn't know.
You're putting the force on your shoulders, and then so you're getting the spinal column and the hips, which is what we're trying to protect.
Dr. Haver, if you could look into a crystal ball, where do you see women's health in post-reproductive years for our daughters, our nieces, our granddaughters? We're Gen X, right? You're blazing a trail for the forgotten generation. We've been drinking from hoses, running around after dark. Our whole lives. No one's really we've been raised feral. We're the feral generation.
And you guys aren't putting up with this.
Right.
But we have to demand that we have significant, when we look at the funding gap for women's health, and not, when I say women's health, everyone immediately thinks reproduction, which is important, right? We need healthy pregnancies, healthy babies, all that. But that's where the bulk of the money goes. And then to breast and uterine cancer. I am more than just breast and uterus. I want my, the most likely thing I'm gonna die of is a heart attack. And so, and how my body reacts to medications, it's different than, we need funding. We need funding for women's specific, gender-specific health. We need training of our clinicians for female-specific health, not outside of reproduction. So this is so important. This is the aging female and how we age. I want that 20% gap between how men and women age. That should be 0.
Dr. Mary Claire Haver, thank you so much for being here. You're incredible. Thank you.